Hey, good afternoon. Hey, here we are. My name is Dr. Elizabeth Parks, and my graduate student is speaking today, Justine Mucinski. And she's been in the lab for over 4 years. And at that time, she's had a lot of service. And I just want to talk a little bit about service, because service is part of an academic life, and graduate students should fold that into what they're doing, whatever kind of service you want to do. But it's part of our mission, and it's really highly valued, and it also helps you learn to project manage. And so Justine has been president, vice president, and treasurer of the Graduate Student Association in NEP. So that's one place where you can serve. She's served many roles in the MU Graduate Professional Council. And at MU, she's received also lots of awards from scientific organizations for her scientific travel to present her results. She's applied for and received the Gamma Alpha Gamma Dissertation Fellowship from the MU Graduate School, which I didn't even know existed, and it's quite prestigious. In her time in my lab, she's published 5 papers, and she has 2 more in the works. And through all this, Justine has really shown herself to be both the expert in terms of the big picture of what our research is doing, and then also the exquisite detail of how to get something done in the lab. And because of that, she's been a great mentor and also resource for other graduate students. Today, she's going to present data from our collaborative project, which is designed to understand the causes of non-alcoholic fatty liver disease and how metabolism changes when one becomes more fit and loses weight. Please welcome PhD candidate Mucinski.
Oh, thank you. I'm going to get rid of this meeting recording. Thank you, Dr. Parks, so much for that really kind introduction. I've enjoyed my time here and look forward to the rest of it. So as she said, I'm going to be talking about lifestyle treatment-induced improvements in non-alcoholic steatohepatitis today. This trial is ongoing in our study, and so we are still recruiting for a few more months, hopefully. And so I'm going to show you what we have up until this point. If we have... Oh, there we go. No? Okay, well, we're going with this.
I can go back in.
If that works. There we go. Okay, so to start, I'm going to go over the background of NAFLD and NASH with a specific emphasis on the role of insulin resistance in this disease. I'm going to talk about the treatment of how we treat NAFLD. Then I'm going to go into the second part of my talk, which is the lifestyle intervention and the regression of insulin resistance and NASH. I have 2 sections here. I'm going to start with some clinical outcomes, and then I'm going to move into the effects on glucose production and disposal. I'm going to start with background. Just a little historical perspective here. NAFLD, or specifically fatty liver, was first described in 1970 by 2 clinicians who found the presence of a lot of fat in the liver of individuals with type 2 diabetes. It wasn't until 10 years later, this hitherto unnamed disease did get a name, which is non-alcoholic steatohepatitis. In the past 40 years, since that paper was published, we've learned a lot on how NAFLD progresses. We know now that a healthy liver subjected to obesity, dyslipidemia, insulin resistance, and genetic factors can result in the accumulation of fat in the liver. This is known as steatosis. And it's characterized by fat within the liver greater than 5% or so of the volume. Now, this is also characterized by lipotoxicity. And when lipotoxicity overwhelms and starts to infiltrate the liver, this can produce inflammation. Inflammation is a characteristic of NASH specifically, along with hepatocellular ballooning, and it can occur with or without fibrosis. And when fibrosis becomes more advanced, this can result in cirrhosis and increases the risk for hepatocellular carcinoma quite a bit. Now, NAFLD is a rule-out disease, which means we go to our doctor and there isn't really a test that tells us we have NAFLD. It is kind of an aggregate of liver enzymes, that are found in the blood, of imaging techniques like liver fat through MRS or ultrasound, and then eventually a liver biopsy might be required. In terms of the prevalence of NAFLD, across the world, we see about a 25% prevalence in the general population. Now, NAFLD is also associated with quite a few comorbidities, including type 2 diabetes. And so in a type 2 diabetic population, we see about 56% also having clinical diagnosis of NAFLD, whether that's through an imaging technique or perhaps a biopsy as well. A lot of this data that I'm showing here is collected through imaging methods like MRS or ultrasound. Now, before I go on to discuss the pathogenesis of how NAFLD develops, I want to show some data from a cohort of obese patients undergoing bariatric surgery. So these subjects we recruit from the bariatric clinic. We have about 220 in this data set. Average age is 47, and these are in the obese category for BMI. Now, during their surgery, we get a very small piece of liver. This is the liver biopsy, and it's sent off to a pathologist, and the pathologist can grade this according to a score, and this is called NAFLD Activity Score. It ranges from 0 to 8, 0 being no NAFLD, and 8 being cirrhosis. In these subjects, we saw a wide range of NAFLD Activity Score, and I think this is really important to know because just because you are in a morbidly obese category, this doesn't necessarily mean you have characteristics of advanced NASH. In this 220 subjects, we see about a third having type 2 diabetes. And when we look at hemoglobin A1C, which is a long-term marker of glycemia or glycemic control, we see a higher hemoglobin A1C in individuals with more advanced disease. In addition to this bariatric population, we also recruit individuals who are undergoing a liver biopsy for suspicion of NAFLD specifically. These subjects, we have 82 of them. Please note this is ongoing, and so remember this cohort because we actually recruit from this cohort our treatment subjects. The average age was the same as our bariatric, and BMI was also in the obese category. In terms of NAFLD Activity Score, however, we see this clustering of more advanced disease in this cohort of individuals. And along with that, 50%, actually greater than 50%, do have clinical diagnosis of type 2 diabetes. And we see a similar trend towards an increase hemoglobin A1C with higher NAFLD Activity Score as well. This didn't quite reach significance here though. So with that in mind, now I want to describe how it develops. How does this disease develop? So we know, of course, overnutrition contributes to obesity, but fat in our diet can also directly contribute to lipid accumulation. Now, at the same time, overnutrition and obesity is associated with insulin resistance. And insulin resistance at the level of the periphery, specifically the adipose tissue, results in increased free fatty acid lipolysis and elevated circulating NEFA concentrations. And this also significantly contributes to hepatic lipid accumulation as well. Now, insulin resistance is also associated with hyperinsulinemia and hyperglycemia. Glucose at the level of the liver can flow down glycolysis through the TCA cycle and back up gluconeogenesis, contributing to endogenous glucose production. And in an insulin-resistant state at the liver, insulin is no longer able to suppress gluconeogenesis, therefore contributing to greater EGP and hyperglycemia. Now, at the same time, insulin is unable to suppress gluconeogenesis. It's maintaining its stimulation on a different pathway. This pathway is de novo lipogenesis. And so this is the process of taking predominantly carbohydrate sources and creating de novo fatty acids. And so insulin at the liver in an insulin-resistant state is unable to suppress GNG, but able to stimulate still lipogenesis. And this is specific specifically elevated in NAFLD and also contributes to hepatic lipid accumulation. So what I just described to you is known as selective insulin resistance. It was described by Brown and Goldstein in 2008. And a lot of the previous literature has focused on the fatty acid side of this story. Today, I'm going to focus on the other half of the apparent paradox that Brown and Goldstein described. And we're going to look at EGP in a setting of NAFLD. We're also going to look at kind of the peripheral counterpart to EGP, which is the rate of disposal. So again, in an insulin-resistant muscle, we are well aware in this group that the muscle is unable to take up appropriately the glucose that's circulating in the blood. So these are the two things I'm going to focus on today, EGP and RD. Now, in terms of NAFLD treatment, there are no approved pharmacological therapies to treat NAFLD. So much of the current guidelines has focused on weight reduction through a lifestyle intervention. And so that occurs through both energy restriction and exercise. Energy restriction remains the most effective option for liver fat reduction. Studies have shown that a 10% weight loss reduces liver fat by a relative 40 to 50%. On the other side, aerobic exercise training can reduce liver fat independently of weight loss. In the studies that have shown a 4 to 5% weight loss, this has resulted in a 30 to 40% relative reduction in liver fat. And no weight loss at all has resulted in a 20 to 30% relative reduction in liver fat. And so these studies that I've just described are using those imaging techniques, and they're not using direct histology to look at level of disease severity. Now, a few studies that have looked at repeat liver biopsies have shown that a weight loss of 5% will reduce steatosis, or the fat that's seen under the microscope in the liver. A weight loss of 7 to 9% is going to help reduce inflammation and the other components of NASH, while a 10% or greater weight loss is required for a reduction in fibrosis. And so this brings us up to the goal of what I'm going to be talking about today, which is to investigate glucose production in a combined program, exercise and energy restriction, with direct assessments of liver health through histology. As Dr. Parks said, this is a co-PI project. Doctors Rector, Ibda, and Parks have all worked on this. And we recruit individuals from that liver clinic cohort that I talked about earlier. And so once they undergo their liver biopsy and they have confirmed NASH, and so for us, this means a NAFLD activity score of 4 or greater out of 8, they can then enter our study and complete a series of baseline tests. These tests include a meal tolerance test, a hyperinsulinemic euglycemic clamp, a DEXA, an exercise treadmill test, and a liver scan to assess liver fat. They then go on and can complete a 9-month treatment of, like I said, energy restriction and exercise. They come back at 5 months when we have another blood draw. They do a DEXA, and we do another exercise tolerance test to reassess changes in fitness. And then at follow-up, they complete the same series of tests that they completed at baseline. And then a repeat liver biopsy is completed as well. We do have control subjects who are also recruited into our study. They receive no nutrition or exercise counseling, but we just follow them and they complete the same series of tests. I'm going to now describe what happens during these baseline tests. These are 24-hour, almost 24-hour tests that people come in. It's over 2 days. They complete a liver scan down in radiology, and then they come up to the clinical research unit where they receive 2 IV lines right away. They then have an evening meal. This is providing about 40% of their daily energy needs. They sleep in the unit throughout the night. And throughout this time, we are having small amounts of blood drawn. And this is equivalent to about a half of the Red Cross donation. So looks like a lot, but it compared to a typical donation. Another IV is placed the next morning. And this is Now the subject has been fasted for about 12 hours. So this is the fasting portion where we measure EGP and RD. And we have an infusion of a labeled glucose molecule going from 6 a.m. to 12 noon. And that leads us into the clamp, which is a 2-step clamp. It's a 2-hour each step, so it's 4 hours in total. And during this time, we're also infusing dextrose and insulin as well. Glycemia, following the end of the clamp, glycemia is monitored. Subjects can consume a lunch of their choosing, and then we remove the IVs and they can go home and rest the rest of the day. Now, I wanted to acknowledge all of these fantastic members of our lab who helped to make these happen. In addition to the CRC nurses, we have people here 24 hours of these studies, and so we couldn't do it without all of them. So in terms of some data here, 17 subjects have entered our treatment, 7 have entered our control. They're both matched for age and weight. ALT is a plasma marker of liver injury. Above 40 is where we start to be concerned, and both of our groups are above that threshold. NAFLD Activity Score was also matched between these two groups. Currently, it is ongoing, but as of right now, liver fat does seem to be higher in our control groups, measured by MRS. And then VO2 max, this is absolute, is a match between the groups as well, and much lower than what we would have expected in a healthy individual of this age. Now that concludes kind of a lot of the background that I'm going to be talking about today. And so then we're going to go into the effects of treatment here. First, focusing on clinical outcomes. Before I do that, I of course have to show you what our treatment looks like. So this includes energy restriction and training. Energy restriction specifically looks like a personalized nutrition program. And our goal here is to reduce the daily energy intake by about 500 kilocalories per day. Now, it's different for every person, but that's our goal on average. And these include regular dietary education sessions with an RD. And so this is our fabulous Jennifer Anderson, who is meeting with these subjects every week and doing a lot of diet wrangling. And she has been very successful in reducing energy intake in these subjects. And this is on average about a 450 calorie per day deficit from baseline to follow-up. Training, on the other hand, this looks like supervised HIIT training. Mary Moore did the bulk of this work. Now, other people have taken it up since she's left. But in general, these are 3 sessions a week. It's about 30 minutes per session. And they look like a 3-minute bout of low intensity, followed by a 4-minute bout of high intensity, and this is repeated 4 times. In terms of exercise adherence, we do see a little bit of a decrease over time. This wasn't significant, but I think this is really impressive still, especially considering this happened during COVID and the shutdowns, and we had to wrangle patients, of course. So now I'm going to show the changes in body composition. And a lot of my graphs are going to look like this. Here I have weight on the y-axis with baseline, interim, and follow-up on the x for both treatment and controls. You will notice that the N is a 12 in treatment. And so that is those are the individuals that have completed all the way through our follow-up study, including the liver biopsy, and the same for controls. Treatment subjects lost a significant amount of weight, both at interim and follow-up. And this equated to about a 12 kilogram weight loss over time, whereas control subjects, we didn't see any significant reductions in weight. Now, in terms of body composition, lean mass loss in our treatment subjects accounted for about 33% of the total weight loss that we saw. And fat mass accounted for 2/3 of the weight loss and the rest of it. And this is a significant reduction in fat mass in our treatment group. Now, in terms of fitness levels, this is absolute VO2 max. Treatment subjects increased their VO2 max significantly. This was about a 15% increase from baseline to follow-up test, while control subjects had no change and marginally seemed to decrease. Now on to some of our non-invasive liver outcomes. ALT is a plasma marker, it's a liver enzyme, and again, above that healthy range is where we start to be concerned of some type of liver damage. And our treatment subjects started well above that line, but did normalize at interim and follow-up. Interesting, our controls also had this stairwise, kind of stepwise reduction, but didn't quite reach below that healthy range. Of course, we're interested to see as we study more people what happens. Now, in terms of liver fat as assessed by a MRI or MRS scan, we did see significant reductions for both our treatment and our control subjects. And in addition to these non-invasive measures of liver injury, we also get liver biopsies, as I've mentioned. And so the liver biopsy is an outpatient procedure. The subjects go in, and when you lay down, your liver is actually very close to the surface of your skin. And so they get numbed up, and the doctor can easily access the liver. A little piece of liver tissue is then sent off to a pathologist who grades it according to a Brent criteria. And so this is the NAFLD Activity Score I mentioned earlier, and it's made up of 3 components: steatosis, hepatocellular ballooning, and lobular inflammation. And the aggregate of those 3 scores is between 0 to 8, and 8, of course, being more severe. So for example, somebody with a steatosis score of 2, ballooning and inflammation of 0 would have a score of 2. They wouldn't be eligible for our study because we're looking for somebody with a more advanced disease. So I just finished showing you ALTs, and I wanted to show you how it's related to NAFLD Activity Score. And in fact, in all 24 of our subjects at baseline, we do see a positive correlation, which just goes in and reinforces that ALT can be a non-invasive marker of liver injury. Now, in terms of treatment effects on NAFLD Activity Score, treatment subjects had a 40% reduction in their NAFLD Activity Score, while control subjects had no change. And the components of which, steatosis significantly reduced. And when you look at the slide under a microscope, what steatosis looks like is all of these little white globules, and those are fat within the tissue itself. And so this was scored a 3 out of 3 for steatosis. Lobular inflammation also drops almost significantly in subjects. And this looks like this aggregate right here is a good example of what an aggregate of lobular inflammation looks like under a microscope in a NAFLD patient or a NASH patient. And this was scored a 2 out of 3 for lobular inflammation. And then finally, hepatocellular ballooning. This reduced about 70% actually in our control or in our treatment subjects. And it looks like, it might be hard to see, but there are 2 kind of swollen cells right here. And what happens is the cytoskeleton within the cell starts to break down, become dysfunctional, and they can be dead or dying cells. In addition to NAFLD Activity Score, we also get scores for fibrosis. Fibrosis is a scarring of the tissue itself, and treatment subjects had about a 20% reduction in fibrosis, while controls didn't. Now, under the microscope, fibrosis is dyed this kind of purple-blue color, and this is actually very advanced fibrosis. It's bridging fibrosis and was scored a 4 out of 4. So up until this point, hopefully I've shown you evidence that our combined program is 1, effective at reducing body weight. This is predominantly through fat mass reduction. 2, it increases VO2 max in our treatment subjects. And 3, it reduces liver disease severity through plasma markers, through an imaging technique, and through histology. So this leads us into the bulk kind of portion of my talk, which is the effects on glucose production and disposal. And so we measured fasting glucose and insulin concentrations. So plasma glucose here on the y-axis again. Treatment subjects had significant reductions in plasma glucose concentrations, and control subjects had this stepwise reduction that we also saw in plasma LT, and this was significant here. Now, I will note about 75% of our subjects do have type 2 diabetes and are controlled on anti-diabetic medications like metformin and others, GLP-1, SGLT2s, for example. Insulin, on the other hand, was significantly reduced in our treatment subjects. This was about a 40% reduction here. Controls trended downwards. We had a lot of variability in the response in these 3 subjects specifically in terms of plasma fasting insulin concentrations. Now, in addition to fasting, we also measure glucose throughout those 24-hour inpatient studies. And so that's what I'm going to show next. Glucose again on the y-axis with time across the x. Subjects come in, they eat that mixed meal, they rest throughout the night, and then undergo the clamp the next day. Baseline shown here in the open circles. We do see a hyperglycemic response following the meal. And then the next morning, around these 7:30 time points, those are fasting time points that I use for the clamp procedure. Following treatment, there was a significant reduction in 24-hour glucose concentrations. And this was also true for our treatment or our control subjects as well. Now, in terms of insulin, we saw a hyperinsulinemic response following that meal. That's likely helping to keep those blood glucose concentrations in check, I showed in the last slide. And then we see a nocturnal decline as the subjects kind of go to sleep and settle down for the night. And that stays relatively low until the next morning when I start to infuse insulin for the clamp. Now, after treatment, again, we saw this significant 24-hour reduction in plasma insulin concentrations. That pattern and the reduction was true for controls as well. Now, I want to describe what the clamp looks like and how we run it in our lab. So at 6 a.m., the subjects have been fasting for about 12 hours. They had dinner the night before. So during this fasting state, the major controller of plasma glucose concentrations is your liver. And so what we do is we infuse a low amount of insulin, and the goal of this step, which is step 1, is to measure how sensitive the liver is. So in a sensitive state, insulin should shut off endogenous glucose production, and therefore we would see a decrease in glucose concentrations if we were not infusing dextrose, for example. Now, during step 2, we increase insulin infusion rates, and the goal of this is now to stimulate glucose disposal or glucose exiting the blood into skeletal muscle. Now, if we didn't infuse anything else, of course, we'd have hypoglycemic subjects. So at the same time, we're infusing a dextrose infusion bag, and this is a variable infusion rate, which means our goal is to keep the subject at the same glucose concentration that they started. And so as you can see here, this is the average glucose concentrations across the 4-hour clamp. And I have been successful at maintaining those glucose concentrations when they come in and do the overnight visits. So again, this is a hyperinsulinemic, increasing insulin, euglycemic, keeping glucose concentrations steady. Now, we also infuse a tracer of glucose. This is in really small concentrations. It's not going to affect blood glucose concentrations that we would, test in a sample, but instead it will allow us to track how the glucose is being produced in the body and how it's being consumed, specifically at the level of the periphery. And so from this, we can calculate the rate of appearance of glucose from the liver and the rate of glucose exiting the blood. So we do that through a glucose kinetics calculation. And so I've just finished telling you that we infuse a known amount of labeled glucose we infuse a known amount of unlabeled glucose in our dextrose. And then we also have this unknown amount of unlabeled glucose that's coming from the liver. So that's our goal. We're trying to measure that. So we have a sample, and it has a pool of all three sources, and we can put that on the mass spec and see how much unlabeled and how much labeled, really small over there, glucose that we have in that sample. Now, I'm not going to go into the calculations, but this ratio allows us to calculate how much glucose is being produced and how much is being consumed. So the clamp technique, for those who don't know, it is the gold standard for measuring insulin sensitivity. It was developed in 1979 and published by Ralph DeFranzo. And before I go on to show you what happened, I wanted to show you a little proof of concept data. So for baseline endogenous glucose production, and this is in all 24 of our subjects, so both treatment and controls, from fasting to step 1, this is when we turn insulin up to a small amount, we did see about a 40% reduction in EGP. When we turn the insulin infusion up even higher, we see an additional 20% reduction in EGP. Now, I was interested and hoped that EGP at fasting correlated with fasting glucose concentrations, and in fact, at baseline it did, in fasting it did. Now for RD, again, glucose being consumed, from fasting to step 1, we really didn't see much of a change. We didn't really expect to. This is a really small amount of insulin. We don't expect much stimulation at the periphery. However, upon increasing insulin infusions, we did see about a 40% increase in the rate of disposal at the periphery. Now, in terms of how treatment affects endogenous glucose production in RD, I wanted to show a little bit of evidence from previous literature, both looking at either energy restriction or exercise training. Now, Peterson demonstrated in a hypocaloric, low-fat diet in an obese diabetic population that EGP was significantly reduced, while rate of disposal didn't really change much. On the other side of this, another study looking at NAFLD patients specifically and doing an exercise training protocol didn't see too much of a change in EGP, but did have a significant increase in RD. So we're curious to see what a combined program is how it's going to affect both EGP and RD, and how those changes may be related to liver histology. And so to show you EGP here, EGP is on the y-axis here with fasting baseline to follow-up. So now, instead of from step to step, within a step in the changes. For treatment, there was about a 10% reduction in fasting EGP when we turned on insulin, we did see a significant reduction in endogenous glucose production following the treatment. And so this means that at the same relative amount of insulin that we're infusing, they were able to turn off the liver to a greater extent. In terms of our controls, interestingly, they reduced both fasting and step 1 EGP. And these data, both for treatment and controls, actually agree with the reductions that we saw in plasma glucose concentrations. And so, of course, I was interested in the change in plasma glucose concentrations, shown here on the Y, with the change in fasting EGP on the X were correlated. And in fact, we did see a positive correlation here. So the individuals with the greatest reduction in EGP were the same individuals who had the greatest reduction in just plasma glucose concentrations. In terms of the rate of disposal, our treatment subjects at baseline or at fasting had a small reduction in glucose disposal at the periphery. However, when we infused a higher amount of insulin, we saw about a 15 to 20% increase on average. So this means after treatment, at a high level of insulin, they were able to take up more glucose at their periphery. Controls, similar story for fasting. However, when we looked at step 2 data, we saw a trend downwards in plasma or in glucose rate of disposal. And so without that exercise and the diet component, these subjects actually reduced the amount of insulin sensitivity at their periphery. Now, of course, I was again interested in if the fasting or the change in fasting RD was associated with the change in fasting glucose. And in fact, we did see the same positive correlation here as well. Now, in addition to this, I was interested to see how the change in fasting, step 2, RD associated with a change in liver histology. So that's what I'm showing here. Again, step 2, high amount of insulin, stimulating the periphery, and then the change in our NAFLD activity score. And so as the numbers are going down, that means the liver is improving. And what we found was a significant negative correlation. So in individuals with the greatest increase in their insulin sensitivity at the periphery, they also had the greatest reduction in their liver disease severity. This was true for both lobular inflammation and hepatocellular ballooning, which again are components of the NAFLD activity score. And so these data suggest that an increased glucose disposal at the periphery may be relieving the liver of excess carbons. And that we think is a benefit to the liver. Now, in terms of fitness and the change in these outcomes, we wanted to look if histology was related to an improvement in fitness. And in fact, we do see a negative correlation here. So higher improvements in fitness levels were the same people that had the greatest improvement in their liver disease. Now, when we looked at VO2 max and the change in step 1 EGP and the change in step 2 RD, we saw positive correlations. And this is especially true and very tight for our change in RD. And so the individuals with the greatest increase in their fitness were also those who increased the amount of glucose being consumed at the periphery. So together with the data I just showed, it seems that exercise may be driving increased peripheral insulin sensitivity, which may serve to reduce liver fat. This is the working hypothesis that we have going right now. So up until this point, our combined program is one, effective at reducing fasting and 24-hour glucose insulin concentrations. It reduces EGP, and it also increases glucose disposal, which was related to NAFLD activity score, as well as the change in VO2 max. So what you can't really appreciate here is that we actually have a lot of variability within our subjects in terms of their dedication to the program and how much they improved if they did. What I wanted to show here briefly is a case study of one, you can't see the title up there, but it says results from a highly dedicated subject. And so this individual came to us. She had pretty severe steatohepatitis with bridging fibrosis. And so her NAFLD activity score was a 7 out of 8. She had pretty high steatosis. Her lobular inflammation and hepatocellular ballooning were at the max level they could be graded, and fibrosis was a 3 out of 4. Now, following treatment, at this point, we're not pathologists, but I hope you can appreciate this looks a lot better than that does. And so, in fact, we did see a complete resolution of steatosis as well as inflammation. Her NAFLD activity score went from a 7 to a 0 here. Fibrosis went from the 3, which again, fibrosis is scarring of the tissue, and it went down to what's known as 1A. So that's very minimal fibrosis. This subject lost 65 pounds. Her ALTs were normalized at follow-up. Her VO2 peak and glucose disposal almost doubled. And so she was much more fit, and she was also able to consume a lot more glucose when in an insulin stimulated state. And so in conclusion, these are just general conclusions. A lot of times I personally am wondering, especially in a combined program like we have, is the liver or is the muscle really the predominant player here? And from the data I showed today, which again was focused mostly on glucose control, the liver seems to be responding to the pull from the muscle. And this is occurring even in a backdrop of reduced plasma glucose concentrations. Now, in addition to this, a lot of people often ask, is it better to eat less or exercise more? And we can't tell you which one's better, but we certainly can say that there is a synergistic effect of both of them when you combine them together in a population of NASH. Now, I've already mentioned that exercise is impacting the muscle, which is dominating over the liver. And I really talked a lot about glucose and glucose tolerance today. But what I didn't show a lot of data on is the fatty acid side of this equation. And so one of the questions that we're interested in exploring further with these subjects is whether diet may have a greater impact on liver fat versus, say, exercise, for example. So this brings me to the individuals that I must acknowledge today, because this took a team to complete even up to this point. The 3 PIs on the project, Drs. Parks, Rector, and Ibda, all of the physicians who help us recruit our subjects. This includes recruitment for the bariatric surgery patients I talked about. They also help our studies. The grad students, specifically want to mention Mary Moore and all of her work with the exercise training. Staff, specifically again, Jennifer Anderson, who's very vital to our nutrition side of this project. Our CRC nurses, who we couldn't run any inpatient studies without, and then the undergrads in our lab currently, who are also a really pivotal part of this team. Finally, our funding, which is from NIDDK, and then lastly, Nutrition Exercise Phys, the department. Thank you for inviting me today, and thank you all for coming. I'd be happy to take any questions. Thank you. Oh, yeah. Okay. Mm-hmm. Okay.
That was a fantastic talk. I really enjoyed it.
Thank you.
The first question is, it appears that the lifestyle intervention also The reason I say that is because after the lifestyle intervention at follow-up visit, the levels of insulin or hyperinsulinemia appear to be a little bit depressed. And that's after you've done the correction to infuse according to the body surface.
That's right.
So it appears to me that it might be exercise training, and lifestyle, and the diet increases insulin clearance. Now, would that be also contributing to the reduction in endogenous glucose production that you see after the lifestyle intervention? Right, you have lesser of a stimulus. Would that be explaining
the reduction in EGP?
To some extent,
I'm gonna
it would not explain your glucose uptake, but it could.
Yeah, I will do that. So if I'm understanding your question, let me get here.
Put your insulin data. Yeah, you see there is less. You see there is less.
There's just less insulin in general.
There's insulin clearance because you're infusing the same level of insulin.
Same, yeah, relative level because it's based on. Yes, it seems like it.
We've seen the same thing, but now you have less of a stimulus for
EGP, right? And so you're thinking that the liver is seeing and clearing, the same amount of insulin, but not putting as much out into the blood, and that's reducing EGP. Is that your question?
Yeah. Isn't it? It's even better than you think it is,
right?
Because you're getting better changes in glucose
with less amount of insulin.
And you're getting even better movement of glucose out of the plasma. So
there's less insulin in the plasma, and we still see a reduction in EGP.
Okay, yeah, that's right. So that's how you should be interpreting that.
Yeah, that's how I would interpret it. Yes. I don't know if that answered your question, but yeah. So did you have another one?
Subject number 2. Do you know if that subject is still
if she kept going. We don't know. The other thing about a lot of these subjects, and I think everybody can agree that there's a lot of lifestyle, just not lifestyle, but life things that happen that a lot of times derail progress. And so we don't know, we didn't follow her, but I hope that she maintained some of the improvements that she saw. I don't know, Jen, if you know anything more than I do about number 2.
She might have gained some back. I guess if you work with a subject for 9 months, it's much more likely that the treatment will stick than if you work with a subject for 1 month, which we've done before as well.
Yeah.
Right?
Yeah, for the audience on Zoom, he asked if number 2 maintained any improvements that that person had. I saw other hands. Dane, yes.
So, I mean, in the etiology of NAFLD, you might have mentioned this, but like which comes first? Is it the insulin resistance that I know it's been contested?
Oh, I don't think I have an answer for you. Unfortunately, we don't know. It's something that's still being looked at. And I would say if you asked 2 different people on different sides of the world, they'd give you a different answer. So I don't have an answer.
Would it be happening independent and in parallel where you?
I would, yes, I think that that's certainly possible to be happening independently of each other. I think the bariatric surgery data that I showed, demonstrates that even if you are a BMI of 49, that doesn't necessarily mean you have a lot of fat in your liver, but that also doesn't mean you're not insulin resistant. So they could be happening independently at the same time, but I don't know which one is driving the other, if they are. Did you have a question as well?
Yeah, I was wondering from your dedicated subject.
Yes.
Like that was profound differences in the histology of it.
Certainly.
Is there anything to say that like the biopsy site of where on the liver was taken might change what you're looking at?
Yeah. So his question was whether if the biopsy is taken from a different part in the liver, if that changes what we see. And my answer to that is yes, absolutely. We are getting, because it's a liver biopsy, we're not doing it during surgery like bariatric surgery. It's coming from the outer core of the liver. We're not going really deep in, but it certainly could be that differences in biopsy techniques or methods or locations specifically could be impacting that. That being said, because the first biopsy was percutaneous, it was from the side, it was relatively a similar location. So I wouldn't expect that to have had a huge impact on what we found. But it's certainly something that we think about. Yeah. Yes, Dr. Beer Potter.
How much can you tell from a CT scan? Like, how?
Oh, goodness.
If you don't know.
I don't know. I do not know the answer to that. Yeah.
Non-invasive. I wonder if you did a CT scan to kind of get an assessment of the whole body liver.
Yeah, scan fibrosis yet.
Yeah. So we can.
But the lipid.
Yeah, lipid for sure.
Yeah. And so we don't do CT scans, we do MRI, MRS, and that gives us a measure of fat in the liver. And like Dr. Park said, we can't do fibrosis, which is why, if we're looking at fibrosis severity, we need to do a liver biopsy.
And you might have said this, but my other question was about diet. So what was the macronutrient composition?
Of each individual person's diet. It changed from person to person. So for example, in general, we're looking at a low carb diet, but not everybody responds best to a low carb diet. We have one individual who we've been working on lately who actually has really high lipids. And we think that's due to a lipase deficiency. And so that person wouldn't respond to a higher fat, low carb diet. And so instead we elected to give a very low fat diet. And that actually brought TG levels down from 900 to 150. So it's different from every person. And that's why we have Jen to work with each person. But in general, we're looking at a 500 calorie deficit.
So that's what everybody's reducing by 500.
That's right. Yeah. Yep. Was there one in the chat?
They wanted you to repeat their question.
Oh, yeah. Sorry. So her question was about macronutrient composition of the diet. Yes, Talia.
Hi, Justine.
Hello.
So obviously, subject number 2 was above and beyond. Generally, a lot of our subjects do have some improvements, but not to the extent that she did. If you take her out, do you still maintain significance?
It's a really good question. And I'm thinking, oh yes, sorry. The question is, she asked me again about number 2, the dedicated subject I talked about in the end, and she wants to know if we still see significance, and I'm assuming in the correlations, if we take her out. And the answer to your question is yes. In general, we do see at least the same direction. Now, some of them do lose a little bit of significance. Of course, we're interested to see as we study more people if we have somebody who improves just as much as she did, and if it's still standing, sitting on that line. Yes.
Sorry for
Dr. Veerpal.
I just have to ask the sex difference question. So I know you have a lot of sample
Yeah.
right now, so I don't know if you're planning on doing sex differences, but I'd be very interested to know if you happen to be comparing sexes in any way.
The only thing that I personally have looked at in terms of sex differences is differences in weight, and we don't see any differences between males and females in how much weight they lost.
What about the liver?
In terms of the liver, I don't have an answer for you. I haven't looked at sex differences in terms of how the liver improves. And again, the question was, she asked me about sex differences in terms of our subjects and specifically the liver. So sorry, I don't have the answer for you. I will say that we have a relatively good, I would say, ratio between male and female in our treatment subjects. We have a 7 to 10. And on average, usually we have more women than males. So it's something that we could definitely look into in the future. Dane, I saw your hand first. Sorry, Dr. Engel.
To piggyback off that, is there like prevalence or incidence for general population and just NAFLD presentation, or?
Doesn't seem like it. It's a good question. We have a lot more females in our groups, but that doesn't necessarily mean there are more females with NAFLD. Yes, Dr. Engwa.
It's just a general question. I enjoyed listening to you.
Thank you.
What are some general valuable lessons you learned being on this project and working with this patient?
Oh, goodness. Well, humans are hard to work with. I think that we know that in this group. So know that going in if you're going to do human research, and just be flexible and try and work with them if you want to retain them. In terms of the data itself, I think a lot of people saw that we saw pretty significant reductions even at 5 months. And we have a lot of adherence issues after 5 months. And so my question is, was 5 months enough to change liver histology? Because we didn't do another liver biopsy at 5 months. So that's something I would be interested in. And then in terms of motivation, why did it drop off after? Why was 5 months kind of this threshold for so many of our subjects that they kind of lost motivation a little bit? Those are just a few things. I mean, there's many more, but those are a few things. You're welcome. Yes.
Can you try to calculate effect size for any of your variables? Because the p-value that you're looking at, the standard deviation mechanism, like your data is pretty tight.
It is, yes. Some of my statistical analysis does calculate effect size. I haven't really looked at it yet, and we're still ongoing, and I'm constantly looking to see, do we have significance in this? And so I'm still expecting things to change and maybe become tighter or not as tight. So I haven't quite gotten to that point yet. Yes, Amadea or Dr. Salvador.
Amazing presentation. And what do 5 years ago, if you can change something in design, experimental design, what would it be?
Well, I kind of already mentioned the 5-month study. I'm curious if 5 months was enough, just because we do see a loss in motivation. Let's see, what else would I change? I mean, it's a good question, and I've had a lot of things in my brain, but now I've forgotten half of them.
Maybe add more outcomes. Don't you think we need more?
Oh, yeah, certainly more outcomes. Yeah, no. It is quite complicated, and I showed you probably about 1/8 maybe of what we have. So yeah, that might be a good answer. Reduce the amount of work that we're doing, but we're going to learn a lot from it, right? We're going to learn a lot from it. So we can talk more about that after if you want. Yes, Dr. Padilla.
Control subjects, your 3 control subjects appear to reduce blood glucose and insulin.
He did.
And do you know if this is just random noise, or is it a real thing?
I think it's real. I think now we have more subjects that were, yeah, that's exactly what I was going to say. We have more. We have 4 that are currently being followed. And so we'll be able to answer that question more definitively. But these subjects are really advanced disease, and they have a lot of risk associated with that. And their doctors have told them this, that if you don't change something, that you could die from this. And so they are scared. And most of our control subjects are trying to change their lifestyle in one way or another. And so we're just trying to follow them free living on what their physician told them to do.
When they enter the study, to some extent, they think they need their lifestyle slightly, or
it's possible. That being said, I think it's really interesting that we see a reduction in glucose, but NAFLD activity score doesn't change at all. So I think something is causing them to change some behavior, but it's not eliciting liver improvements right now. So something I'm personally really interested to see if that changes.
I think that's what happens in lifestyle interventions anyway.
It's just,
it doesn't matter if they're randomized to control something. Just the fact that they're in an intervention.
No, they're
whether
scared.
getting it or not,
They have been told by their doctor, you got to change something.
They all want to make change.
They all want to make
They all want to. I would say the control that we have, an AZ
May and B.
and B.
We use 3-letter codes to identify our subjects. So
I mean, I would say they didn't make as many changes collectively as the treatment, but they're still all really well. At least
They're trying.
Yeah, they're trying.
yeah, what Jen said was that all of our subjects, regardless of treatment or control, whether they were randomized to one or the other, they all want to make a change. I'm just saying that's for Zoom here. Some of them do more so change than others, I would say. It's really dependent on the person. More questions? Alan.
What was the sort of time gap in between?
It was controlled. We want a, oh, I'm sorry. Yeah, I keep forgetting to repeat. So Alan's question was whether or not we control for the final training session before the final inpatient testing that we do. And I'm going to answer for that and for the follow-up liver biopsy. And so we usually have them exercise within 3 days. Now, of that either the follow-up liver biopsy or the follow-up inpatient testing, this is just going to be based on their individual schedule. It takes a lot of, kind of just time and moving things around to make it happen for them to get into the gym. But that's our goal. And almost everybody has gotten within that 3 days before the last.
Exercise within 3 days of their inpatient visit?
Yes.
So you could have had someone in on a Friday exercising, then kick them in.
So they would exercise on Friday. They would come in Saturday night, stay overnight, clamp on Sunday. Brian, did I see a hand?
Yeah. It's kind of piggybacking off of Dr. Potter's question, but more on the rate side.
Okay.
Has there been any studies or anything that looks at like the prevalence? So like for instance, the African Americans, they have a higher risk of cardiovascular cerebral.
Sure.
Type of kind of like that with NAFLD.
Yeah. So his question was whether there was higher prevalence in, for example, African Americans, and we actually see less prevalence in terms of African Americans specifically. However, when they get NAFLD, they get really sick. So they advance through the stages what seems like quicker than say a Caucasian population. So there are racial influences there as well. You're welcome. Are there any in the chat?
Thank you so much.
You're welcome. Thank you.